Hey there, and welcome back to this episode of the OncoPT podcast. Today is an exciting podcast episode because we are talking about some current events, y'all. I don't feel like we get to talk about that a whole lot on this podcast. You know, it takes a while for research to come out, whatever, but this is current. This is has happened within the last couple months and has direct implications on our practice. And so I'm so thrilled to have someone who has been spearheading the Lymphedema Treatment Act on the podcast today to talk all about it and what some of the recent developments have been. So, welcome, Sarah Bramblette, to the OncoPT podcast.
Hi, thank you for having me.
Oh my gosh, of course. Sarah, would you mind introducing yourself?
Sure. So, again, my name is Sarah Bramblette. I'm actually the board chair of the Lymphedema Advocacy Group. I'm also a lymphedema patient. I have secondary lymphedema to primary lipedema. I'm also a Medicare beneficiary because of the lymphedema in my lower extremities. I am on disability, SSDI. I've been, so interestingly enough, I have always fought with insurance to get my compression covered. And I can remember hearing about the Lymphedema Treatment Act in 2010. And I actually started reaching out to my representatives in Congress at that time. But I didn't actually join the Lymphedema Advocacy Group until 2014. They had a lymphedema lobby days in Washington, D.C., and it piggybacked off of the National Lymphedema Networks conference in D.C. And I participated in both. And leading up to that meeting, I had gotten involved. I was on my state team and I got involved in scheduling meetings. And so NDC was the first time I met Heather Ferguson, who is the founder and executive director of the Lymphedema Advocacy Group. And we just kind of hit it off. And I was actually at that time in the midst of working on my master's in health law degree. And so I kind of have gotten that to help, learn more so I could do the advocacy work. And so after that time in DC in the fall of 2014, I actually joined the board of the Lymphedema Advocacy Group in 2015 and have just, worked since then. When our past chair unfortunately passed away, she had breast cancer related lymphedema. She passed away and I kind of filled her shoes, which is a very fast shoes to fill. And then Heather and I are just really, we're an all volunteer group, grassroots, and we have an excellent group of volunteers, even state team advocates. But, I kind of like Heather and I are really the partners kind of leading things. We bounce things off of each other. We're always texting and things. And so we're kind of the ones in the nuts and bolts of everything involved.
The very first time I heard about the Lymphedema Treatment Act was in 2018. I was at my CLT school experience, right? So I'm training to become a lymphedema therapist because I actually had my clinical instructor in physical therapy school said, you need to go and get your CLT. And I really didn't have a whole lot of exposure to lymphedema before then. And I had no idea that the Lymphedema Treatment Act was a thing. So can you tell us a little bit about what is the Lymphedema Treatment Act and why it's so important?
Certainly. So the Lymphedema Treatment Act was a bill. It's now a bill that's passed into law, but it was a bill to close the unintended gap in Medicare coverage. So Medicare didn't cover lymphedema compression garments or supplies. Now, we know some private insurance did. Of course, there's the Women Health and Cancer Rights Act that kind of covered it for patients with breast cancer. But Medicare didn't cover compression because it didn't fit under DME. So the definition of durable medical equipment is that it's durable, and they have that definition as lasting 2 or 3 years up to 5 years. And as we know, lymphedema compression needs to be replaced about every 6 months. We know some patients make it last longer, but the recommendation from manufacturers is every 6 months. So it wasn't a disposable supply and it wasn't a durable supply. So CMS just said we cannot cover it. Heather, so while we had the Lymphedema Treatment Act in Congress, they also were asking CMS, can you cover it under prosthetic devices? Can you cover, they're covered under surgical supplies if the patient has an open wound, but as soon as that wound is healed, they're not covered. So it was never that Congress didn't, or CMS didn't recognize lymphedema as a disease. It was never, there was a lot of these Sometimes patients just said they don't care about us, or they just, they don't recognize lymphedema as a condition. It was just that CMS felt that their hands were tied because there wasn't a benefit category that defined them. I had even paid out of pocket for compression and appealed throughout the entire process of appealing to CMS. I had an administrative law judge hearing over the phone. I took that negative to the administrative, or it was like the CMS appeals council, and they even said yes, it's medically necessary. Yes, she needs them. It's they kind of said it's not upsetting. How do they say it? I don't know, but they just said, unfortunately, we cannot pay it because it doesn't fit under one of our payment categories. So the bill is relatively simple. It says we create a benefit category. There was some discussion of just putting it under DME, but CMS wants it as its own benefit category. So it's going to be its own benefit category under Medicare Part B for the coverage of standard and custom fit lymphedema compression garments and other items as determined by the Secretary of CMS, because we wanted, or HHS, we wanted to make sure as other items come available that we don't have to go back to Congress, because this was a 12-year. The initial bill was introduced in 2010. This was a 12-year journey to get it passed. And so we want to make sure the Secretary of HHS and CMS administrators have that flexibility to change things or add things through the administrative and regulatory process versus having to go back to the legislative process.
I had a visceral response to the thought of having to go back and redo part of that. So I'm really glad that y'all had the foresight, because, oh my God.
Yes. So we certainly didn't want, so the interesting thing is we know this, compression is the most cost effective, component. It works and it's not expensive. A lot of people say compression, when you're on Medicare and you're either elderly or have a disability, you are on a limited income. So to us, it does feel expensive. But in comparison to medications that are out there or other items, it's not expensive in the scope of what Medicare is paying for. It's not expensive in the scope of hospitalization for cellulitis. So, we talk about this is really, it is pretty simple. Like we're wrapping a leg or we're putting a garment on it. It's amazing though, the difference it can make when patients have the access to these compression garments. But we know compared to other diseases and other conditions, there's not been a lot of progress. We do have some new items on the market. There is surgery, but even with surgery, compression is recommended. But there was kind of a running joke because at one time we were looking, usually a bill our size needs to be added onto a larger package to move and to get passed in Congress. So several years ago, there was the 21st Century Cures Act. And because it was related to healthcare, we thought maybe we could take a ride with that bill. And we mentioned it to an office. It was after the bill had already passed and we weren't included. We mentioned it to an office that we had hoped we had taken a ride with it. And he said, this, what I'm looking at isn't 21st century cures, he said, this is 18th century technology. And he didn't mean it in a mean way. We all joked, we're we know, no, we know, but it's what we got. And it works well. But with all that said, that's why, hopeful as things are advancing. And my hope really is with compression now being covered, it's going to improve the overall care that patients get. Because we know, for example, to even start compression therapy with an OT or a PT, they need bandages. And if those aren't covered in the clinic, some clinics are able to provide them for patients and some clinics might just not have it in their budget to provide them. So telling a patient you need to buy these bandages before we can even start therapy might be a barrier to their access. Same with compression pumps. We pointed out that, Medicare coverage of compression pump says we're not going to cover a pump for you until you fail at conservative treatment with compression garments, but they don't cover compression garments. So how can a patient fail at treatment that's not covered? So I just really hope as a patient, this is going to open up not just patients having access to the compression garments, but then for just an improvement overall in what we're doing with lymphedema treatment, because we are well aware that lack of coverage or compression isn't the only barrier facing patients in the country.
Right. I think it's really interesting. The 18th century comment like definitely stings, as I'm sure it like stung everybody in the room. But there's a snippet of truth to that. Like, and
Mm-hmm.
I think about, because my background is cancer oncology, the strides and the gains that we have made and the treatment of cancer over the last 20, 30, 40, 50 years is tremendous. And we're treating cancer completely differently than what we did in 1950, thank God. But lymphedema has not really seen that level of advancements. And I imagine that very well could have contributed to some of the challenges. I mean, you mentioned earlier, Sarah, about how this has been a 12-year process. I mean, like, how frustrating that must be. And I kind of have to wonder, like, how much, did that maybe like hinder us, kind of our progress in making this happen sooner?
That was the biggest challenge, is the educational component. So when we, even once I started in 2014, the first thing you did when you went into an office was say, we had to educate them on not only what lymphedema was, but the role that the compression garments play in treatment, and then why not having compression garment coverage is, harmful and cost, complications. And I just want to right now take one step back, because I know I mentioned like the other issues in treatment, and we get this question a lot, like, why did this bill only cover lymphedema compression? Why didn't it cover, say, surgeries, which are, up and more information? Because, as I mentioned, the issue was a benefit category for compression, whereas there is a benefit for surgery. So while surgery might need better coverage, you could do that through the administrative process. We can take information, we or anyone can take in information. So that's why we needed an act of Congress to create that new benefit category for compression, whereas some of the other issues facing patients, and either surgery or maybe number of visits, I think that hopefully with the therapy cap getting corrected, we don't have that as much. But some of the other issues are issues that definitely need addressed, but don't require an act of Congress. And there was several years ago when Congressman Reichart was our lead. He's the one who kind of took over the bill. Heather had passed a state bill in North Carolina, a state mandate, and then her congressman in North Carolina helped get the federal bill introduced. And then unfortunately, he didn't get reelected. So Congressman Reichart from Washington State took over, and his first thing was, we need to make sure this bill is passable. And so there were some other aspects to the bill that didn't need to be in it. But Heather's vision was every patient needs compression, So, and as I mentioned, no matter surgery, no matter type. Now, Heather's is in this because her son has primary lymphedema. So we wanted to make sure primary, secondary, no matter the cause, gets compression garments. Like I said, we needed this bill because that was the one major cornerstone of treatment that needed the act of Congress. So the other things we can address through CMS, and I'll mention them a little bit later also.
Yeah.
But as you mentioned, cancer treatments are coming up, are improving. Cancer survivorship rates are increasing. And with that increased survivorship, there's likely going to be an increase in patients developing lymphedema. We bring that up with the president's moonshot. It was previously when he was, so every time they talk about the cancer moonshot and doing more for cancer survivors, we kind of like put our hand up a little bit and say, this aligns with your goals of that. This is a huge survivorship issue. But we find that a lot of, in the oncology space, a lot of patients are maybe told this, and they're so they're so relieved that their cancer has been treated and that they're cancer free, and then they find out about lymphedema. And sometimes, unfortunately, they're told, like, it's no big deal, we saved your life, what about? But it is a big deal, because it's now like a chronic condition that doesn't get as much attention and support as when they were going through cancer treatments. I mean, I know an example of, I know there's charities out there, nonprofits, that help cancer patients with rides or co-pays to cancer treatments.
Mm-hmm.
But the same isn't true for rides or copays to their lymphedema care,
Yep.
even though it's cancer-related lymphedema.
Yep.
So, yeah.
Yep. You bring up a really good point. I'm so glad that you incorporated the moonshine, like the moonshot, because
Yeah.
again, it's like, oh my God, in my world, it's like, oh, this is perfect. But again, I feel like we're really, unfortunately, acutely aware of some of these issues that patients are experiencing. It's like, that's amazing. Now, here's what we need to do to actually like make that a reality for so many
Yes.
patients who are actually living longer. So, my next question, Sarah, is, you really established the compression part was one of the biggest barriers that needed to be overcome because of like, there kind of wasn't a place for it. All the other, services, the other components of complete decongestive therapy for patients, there's kind of a place for them, but there really wasn't for that covering of compression when it came to Medicare. Now, I know there's somebody out there who's listening. Well, Medicare's great, right? But my patients aren't necessarily all on Medicare. So what does this mean for patients who are on, like other insurance coverages,
Certainly.
etc.?
Yeah. So what most people don't realize is Medicare sets the standard for other private insurance to follow, and including Medicaid. And so, but in our research, we found that actually 44 states have some type of language in their Medicaid coverage regarding compression coverage. Now, I think a lot of patients might say, oh, I live in one of those states and I don't have coverage, but it's because there might not be an actual vendor who has a contract with the state.
Yeah.
So we're hoping as that Medicare coverage kicks in and more vendors become available. But I will tell you, because I'm the person who like looked up every state. And so that was several years ago. And then I looked it up again. Well, because in Ohio, it's covered by Ohio Medicaid. Unfortunately, I wasn't eligible to be what they call dual eligible, but I did have a friend who was dual eligible. So she got her JOPS Alvarex compression covered by Medicaid. And when I talked to Senator Brown's office about that, that Medicaid coverage was a real like important point to them and understanding the need for this bill. And so then someone else asked about it. I said, well, I'm just going to check all the states. So that was maybe in like 2018 or 2019 that I did that. And of course, we looked up a lot of links. And so those links no longer worked for our list because, if Medicaid. So this past year, I looked up again, and 3 states that didn't have coverage before actually now have coverage for Medicaid. And one of them, I think it was the state of Oklahoma, actually cited our list as part of the reasons that they had added. So, I mean, there's even been behind the scenes progress in some of this. We also have some other states that did mandates. Maryland has a state mandate, North Carolina that Heather did. I think California has some type of mandate. But now sometimes those state mandates. So my point is Medicare will make a uniform and coverage for everyone to follow because Heather lives in North Carolina. There's a North Carolina state mandate that she helped get, but her family's insurance is through her husband's employer and is based in Georgia. So the North Carolina state mandate doesn't actually apply to that insurance. Or sometimes, and this might get too deep into things, but sometimes state mandates only don't apply to self-funded insurance because that is handled by ERISA. So there's a lot of nuts and bolts to it. And that's why Heather, after she did the state mandate, she said, my son might not live, he might go away to college. He might move. He's not going to always live in North Carolina. I want to fix this at the top. And so that's why she fixed it. But we do hope it goes down. And and I don't want to jump ahead because I know you asked what next steps are, but we certainly want to, for any part of our plan in the next step is to give a heads up to all the states and all the private insurance that this is coming down the pipeline. So Medicare coverage starts January 1st of 2024. We're hoping as many possible will start. And this is the other little thing I like to mention because we talked about how awareness of lymphedema and awareness of lack of coverage was part of what we had to do to work on this bill. And now this bill had been
Right.
the most supported healthcare bill in Congress the past 3 sessions. So we went from, having to explain what this bill was from, offices knew us, offices knew our bill. We have such a good relationship and reputation on Capitol Hill. And then we also had offices where we would walk in and say, "Are you familiar with lymphedema?" And the young staffer said, "Yes, my mother has it. I used to help her wrap her legs." There's also staff members. There's members of Congress. Senator Heidi Heitkamp had lymphedema from breast cancer. So certainly it was aware. And there was other staff members who would share with us personally that they did have, lymphedema, or they had a family member with lymphedema. So that was probably our biggest accomplishment also. But there was such a huge piece of education that went aware of it. But we did such a great job at raising awareness of the lack of Medicare coverage that one of the insurance companies that I had through my employer in 2010. So when I had an insurance through this insurance company in 2010 through an employer, I had $10,000 DME coverage, got all my compression garments covered, no deductibles. Great. I actually, and I'm not going to mention the name of the insurance company, but recently I took a part-time position with this insurance company. And I thought, great. I know they had like excellent coverage before. And of course the policy would change, but thought I could purchase, even though I was part-time, I had the option to purchase the health insurance. And I looked into the fact of if I purchased the health insurance as secondary to my Medicare, if it would cover it. And at the bottom of their, so they no longer cover lymphedema compression as of 2018 to better align with Medicare coverage. Yes. So that's how much they are watching, and they do follow Medicare, because as soon as some of them found out that Medicare wasn't covering compression, they updated their policies to better align with Medicare coverage. Yes. So for any patients who aren't currently on Medicare, that it does, hopefully all of them were better aligned with the better coverage that Medicare is going to provide.
I know you don't necessarily have a crystal ball, Sarah, but I'm sure there's some kind of like precedent. Do we have any like projections or predictions on how long we could expect to see like some of the major insurance companies, like how long it takes them to adopt that what Medicare is doing?
We don't. I'm hopeful that once, so Medicare, so right now CMS is working on the rule and working on the coverage details. Okay. And once they have to be out in time for there to be public comments, which we can discuss. And so I think my point is, it's not going to be like December 1st, boom, CMS is going to, we're going to know what CMS, the coverage is going to be like mid-year. There's going to be some time for them to take public comments and tweets, but Medicare has to have it, together for all their information to be ready to go, including, their Advantage plans and things like that. So there should be enough to kind of get the information out there for these plans to implement it. I would also hope with, this is coming from me because I've done it before, but I would hope with even the coverage in place that patients, even if it doesn't say they have coverage, can push back and appeal and get things covered. I would hope no longer than a year. Like my hopefulness would be that they get on board for it to start. I think that's probably wishful thinking, but I would hope at least a year into it, it would. I know. So this might just, I'm trying to think. So working in oncology, so you know how the guidelines for colonoscopies just changed to age 45?
Right.
So I turned 45 in September and I got the notification you're due for this, but it wasn't yet covered, but it wasn't covered. But as soon as January happened, I was getting a message wanting me to schedule something. And I said, well, but I didn't think it was covered, at my age yet. And they said, oh no, it changed in 2023. So some things can be quickly updated.
Okay.
And hopefully, that's our goal, is to at least get the information out there. So it gives them the heads up, to cover it. And a lot of them have been covering it just under different, like I know when I had the coverage, it was covered under durable medical because a private insurance can define durable medical however they
Right.
want to. Yeah.
That's true. That's
So
true. Okay, so it's law. We're done, right? Like everything's taken care of. There's nothing more to do.
Heather and I even knew there would be more to do, and we're still, I think, feeling um, we still had no idea it was this much to do. So we
Yeah.
are currently, and if anyone who, if you go to the lymphedema treatment act.org, you can sign up for
Mm-hmm.
our newsletter. So Heather, the newsletter
Mm-hmm.
that just went out this past week mentioned about, it might be quiet from us, but there's a lot of work going on behind the scenes. Currently, stakeholder organizations are having listening sessions with CMS, which is providing them their like information about compression use in their organizations and their wishes to see how coverage is implemented, because we want to make sure that patients have the quantity of garments they need. And so a lot of times people talk about 2 garments every 6 months. Okay, but some patients require more than 2 garments because like I have
Mm-hmm.
lower extremities, so I need at least 2 garments at one time, not,
Right.
and or I actually wear knee highs and capri, so that's actually 3 garments as one set.
Right.
So we want to make sure there's no misinterpreting that, because I've heard that happen to
Mm-hmm.
other patients where they're told 2
Mm-hmm.
garments and they get a pair of knee highs and the company's like, that's your 2, and they're like, no, I need 2 set, I really need 4. So
Right.
we want to make sure that is completely understood. We want to make sure, um, again, for any type of lymphedema, which that is in the bill, but we also want to make sure they
Mm-hmm.
understand that lymphedema can happen anywhere in the body, not
Mm-hmm.
just limbs, not just
Right.
extremities. It can happen in the trunk and the chest. It can happen in the head and neck. So
Mm-hmm.
we're just educating it again, like how we had to educate Congress of why we needed the bill. Now we're really educating CMS on what the needs are of this coverage. Coverage will do us no good if it's not implemented the way we need it. So the Occupational Therapy Association is one of them that is having a listening session. The American Physical Therapy Association is also having a listening session.
Okay, good. I was worried. I was like, they
Yes,
better
no,
be.
no, yes. We have, so CMS reached out to some organizations, but we also gave them a list of organizations that we thought they should
Okay,
reach
cool.
out to. And then we reached out to those organizations and let them know they could request their own listening sessions also.
Okay, cool.
Because, again, it's part of the education. CMS might have known, I think they've, are told certified lymphedema therapists do this treatment, but they might have not known what umbrella organizations those belong
Mm-hmm.
to.
Mm-hmm.
There's
Yeah.
also a group of compression manufacturers, Compression Alliance, who are meeting that really
Mm-hmm.
explain what each type of garment is needed, the daytime, the nighttime, the reduction. I feel like we have a really great group of people. I mean, we've always had, I mean, if you go to our website and see their list of stakeholders, we've always had a great diverse group of stakeholders. And so now
Mm-hmm.
they are all coming together and providing that information to CMS.
Mm-hmm.
But because it's rulemaking process with CMS, they're not allowed to tell us a lot of things. Like we're allowed to just give them
Mm-hmm.
information, but they're not allowed to
Yeah.
speak on anything. Once they have
Mm-hmm.
the draft rule, or the rule drafted, it'll be posted publicly, and there'll be a 60-day comment section. And they expect that to happen, what they told us, mid-year. So we're thinking June
Okay.
or, July, and it'll be 60 days. At that time is when, we'll ask people, depending on what the comments say, we will, um, you know, encourage our advocates to, comment on, whether they love them, it's great, or if there's anything they'd like to change. Um, and at that time, in the past, we've always had like templates that, you could just put in a little bit of personal information. For public
Yep.
comments, we're really going to need people to share their personal experience and why things are needed, because
Okay.
CMS actually does read the comments. And so it's not necessarily about
Mm-hmm.
quantity of how many come in, but really the
Yeah.
quality of
Yeah.
what people are saying.
Okay.
And so, but our plan is to Right now we're working on the listening sessions. Once those are completed, we're going to work on an educational campaign of, when the public comments come out, this is, we're not going to probably give a template, but we're going to give the points to talk about, and really encourage people to, submit their own personal experience. And we still have those personal experiences in our stories because we've had people submit those, but especially, the therapist, anyone new to this, would just really make sure that CMS, and again, it'll be commenting on what is posted, and we don't know what's posted yet. So certainly if there's anything huge that we think needs changed or anything like that, we'll definitely want people to voice their opinions on that. So then once the 60 days are up, I don't really know what their time frame is or what changes they make to it, but I think typically open enrollment for Medicare starts like November. So there won't be a whole lot of time. And it's interesting because we have some people say, why do we have to wait a year? And it's like, oh, well, I mean, we waited 12 years. So one more year to make sure we get it right, we can do it. Trust me, as a patient on Medicare, I feel it, and then also I'm like, I'm going to have my measurements ready January 1st. So let's get these ordered.
Right. Get that
Actually, I'm more thinking like I'm going to be your test case, like whoever the vendor is, like I'll be your test case. You can see how this works, and see how well it goes. Because of course, let's be honest, because anything that's already covered, we still know sometimes there's issue with coverage. So we expect there will be some hiccups. So just like what the laws passed, now we have this, there'll probably be a period of time where we have to make sure things get, ironed out and that things are working well. Yeah.
I'm feeling so much emotion with this conversation. First of all, I am in disbelief at how much work is going into it passed, right? Last year it was signed into law. I just remember throwing a dance party with some of my therapist friends. And then, it was like, okay, January 1st, this is kind of where this new phase of this process kind of comes on, and just the amount of steps that are having to be taken and followed to make sure that this is going to come into. And that's one of the things that, that kind of, got me thinking about this interview with you is I have a friend who is now working, more with a compression garment company. And so I asked her, because I was like, she knows information, I'm sure. And she was like, well, we actually don't know, and here's why. And I thought, oh, I need to educate myself on this a little more, because there's clearly things happening that I don't understand. So, man, Sarah, you've... my brain feels a little exploded right now because of just how much that was, but it was so good. It was so good.
Yeah. I mean, I'll admit, and there's some conversations happening with CMS that I didn't even think there would be conversations, but I am so glad that this is a patient-led matter, but so the Lymphedema Advocacy Group, we're taking the lead, but we have told all the organizations, please have your own session. We don't all want to, we have some certain points that we want to make sure everyone agrees on, like all types of cancer, all areas of the body. So how, we want to make sure patients get enough quantity to begin with and the frequency of how many times they need it. And for me, it's so difficult to, we were having this conversation of, how many sets of garments and how often, and the realization that I've never, even when I had insurance coverage, I've never had the recommended number, because we would always order one set and make sure they fit. And then by the time insurance actually paid for them, it was time to measure again and order a new set.
Yeah.
So I have rarely, if ever, had 2 sets every 6 months. I mean, it's really, and you start talking about how we just adjust, and we, I've worn garments longer than needed, and I shouldn't have, but I did because you had to. We didn't have coverage.
Right.
So yeah, but the good thing is everyone's on the same, page of making sure this is done right and what's best for the patients. And it's just some questions that are popping up. You're like, oh, I didn't think about that. But my ability to bring in the patient perspective, and then I know the policy too, is like really, really helpful. So, um, but yeah, and like I said, hopefully this changes. We're having in these discussion, uh, in the planning sessions with, occupational therapy groups and the physical therapy groups, some of those other issues with, the coverage of therapy, or, patients having access, not just coverage, but access, rural areas, home health. That's something that I've brought up to CMS, and we have if you go to our website, we have a link to frequently asked questions. We put some frequently asked questions out there for patients and anyone following us. I think it started maybe 10, 15. And we said, if you have questions that aren't on the list, let us know. And it's now up to 40. So now not everything has a complete answer. Some of it is that we don't know yet. But one thing that I brought up, because it affects me, it affects a lot of people I know who have advanced stage lymphedema and late stage lymphedema, is how will this benefit coverage interact with their Part A home health coverage? Like I actually have home health, but I have right now, I've been able to get the Velcro garments by another means. But, there's a rule with Part A of, if the home health agency's providing care, they have to provide everything. So would this be like wound care supplies where the agency actually has to have the cost of it? Or would it be like a wheelchair where you would just use the Part B benefit for the patient? I don't have the answer to it, but we've made them aware that patients get lymphedema treatment in different settings, and we want to make sure that this benefit category works in those settings. And then I also mentioned, and speaking to the therapist, that one setting that unfortunately patients are in and they don't always get the care is long-term care facilities and nursing homes. And just because usually the OT and PT are more focused on those activities of daily living, not necessarily a chronic condition, but patients who have been diagnosed and maybe when they were at home, had garments and things, it just needs to be something we address and then make sure, again, that this benefit category works in conjunction. However, I'm not, I don't know the answer, but we just need to make sure that patients get the garments they need in whatever setting they're getting the other type of Medicare benefits through. So
I'd like to ask a question, and I did not prep you on this, but it kind of goes into some of those, like, these not afterthoughts, but these other kind of considerations that are coming about. So we've been talking about, it's really important that patients are able to get the quantity, excuse me, of garments that they need, again, specific to their specific presentation. One of my thoughts, because I've seen this as a therapist, is I have patients who have lymphedema who will actually get on insert online store of your choice, and they get the quantity of garments but not the quality of garments. Is that something that y'all are also addressing?
So these will need to be medical grade and will need to be a prescription for them. And there will be you'll have to be like a Medicare supplier. There might be a way, because I know someone did ask, like, can we purchase them and send in for reimbursement? And of course, Medicare has that ability, for care, that you can submit your own claim. But I don't know, again, all what the details will be. And we have also heard from some patients, or we've heard people who say, like, I just want to be able to buy a lot at one time. And that's really not advised. I mean, if you're needing to wear several at the same time, but it's not necessarily advisable to stock up, because measurements can change. I mean, I know for some patients they don't, but things can change. So yeah, there still will be, these are lymphedema. These aren't sports compression. These will have to be lymphedema compression garments, the medical grade, I kind of know all the classes, but they start like at 10 or 15 and go up. So yeah. And so that's another issue too. I'll just say this right now. I wear custom lower extremity. So my cost for compression is higher than, say, maybe a patient who just needs a single arm sleeve Um, sorry. So, the difference between cost of a standard fit off the shelf or a custom fit can be different, especially for how many you need. And just a reminder, in case people aren't familiar, especially if you're not on Medicare, coverage still means under Part B that you'll have your 20% patient responsibility. So this is still going to be a cost for some patients. I mean, even for myself, I think my garments, one set, I haven't purchased a set. I've only purchased the knee highs out of pocket, but a whole set for me, I know at that time was about $1,000, and that's just a set. So I would still be paying about $200, possibly, how things, the magic of insurance sometimes, but I'm still looking at possibly $200. So, so then maybe a patient who can just wear a sleeve that's standard fit and it's $80, they might just prefer to get them from where they're interested. Maybe try to submit the claim, or maybe, I don't want to sound like this, but maybe don't mess with it. I don't want to sound, nonchalant, but for some patients, if they already have what they wear and they get them from someone, it just might be that they don't bother. I know, years ago I was kind of in between insurance, and I went to my doctor for a checkup for like self-pay, and it was like $80. And I thought, wait a minute, I pay more than that, like for the time being. Like some people are so worried about not having something. So I can see, like, if something they're ordering is, I'm still not trying to get to it, but it's possible they're using something that works for them that might be more cost effective for them to self-pay it than what something else is. But I think that, I know for but for the later stages, or the ones who need the custom, it's going to be, more. So and I haven't needing custom. I haven't ordered, online much. I've ordered some so a couple years ago, I was having like recurrent cellulitis, and I was ordering some of the padding or some of the chip bag. Actually, I made my own chip bag, but I ordered some of the like bubbly, like padding to maybe try to break up the fibrosis. Well, it was during COVID, so I couldn't get like any care, like clinics were closed and everything. So I was trying to making my own chip bag was interesting. Like cutting up old foam and putting it in a sleeve and actually stitching it by hand, because I don't have a sewing machine, but I was just trying to do anything I could. So I don't have a lot of experience working with that, but that's a whole nother aspect. Is there are legitimate retailers who are selling lymphedema, garments. There's people who aren't selling lymphedema garments, but working on how this will work with coverage using online suppliers is a whole aspect we're looking at. But yeah, the what's going to be covered as a lymphedema garment is certainly going to be defined, and you'll have to have a prescription in order to get anything reimbursed. Well, and so some people were concerned that everything's going to be reimbursed, but in order to get the coverage, it'll have to be something that's prescribed by, the treating doctor.
Yeah, that definitely helps, because like I said, I've had a few patients kind of early on in my career who were like, well, I bought this on Amazon. I'm like, no, you should not have, because we could have got you you got 8 for the price of 1, but those 8 are gonna be done in like a week. So thank you for addressing that, Sarah. So as far as we know that there's still work to be done, right? What can we be doing now? So like, as the individual clinician who's listening to this right now, what can I be doing now and in the coming months to make sure that this turns out the way we want it to, so that our patients can get the coverage that they need and the appropriate garments for their presentation, again, whatever that looks like for them?
I mean, I know, like, overall, when we're thinking about the sheer number of advocates that we have, is when that open comment period comes to give feedback on that. For now, though, if you have patients and you have patients on Medicare, let them know that this coverage is coming, so that they know to look out for it. They know to, I think that'll be the biggest part too, is making sure patients know. And I would assume the vendors and everyone know, but also making sure your colleagues know that's coming down. We still have patients who say that they get limited, that they can't get all the manual lymphatic drainage services they get because Medicare limits it. And I thought, no, the cap should be lifted. And if you still need it, there should be a way for you to get what you need. So there's still not a lot of knowledge out there that some of those changes have been made, even on the making progress. They said I can't do anything because I'm not making progress. That definition has changed. You don't have to show improvements or make progress, especially with lymphedema. Sometimes it's just maintaining what we can do.
Absolutely.
So that's going to be the biggest thing. Watch for end of May, beginning of June is probably when we're going to know when those public comments come out. And then we need as much feedback on them as possible.
The Lymphedema Treatment Act website and email newsletter, I believe, are jam-packed with information. And I mean, really good job on updates that are going on. Sarah, can you share the website and then how people can get on the newsletter so that they can get these updates as they come out?
Certainly. So the website is lymphedema treatmentact.org. And we also have a Facebook page. But when you go on the website, if you're specifically looking for the newsletter, it's on the bottom left-hand side. And it'll say, newsletter. And if you want to, you can click to look at previous newsletters. And then you can click, there's a subscribe button. And you click on that, and then you could subscribe, and you'll get no more than once a week, especially now, not even maybe once a week. But even when we were pushing for the passage, it was at least, we just try to let people know, keep them engaged is how we would phrase it. We wanted to keep them engaged, let them know what's going on, and if there was action that was needed at the time. And so certainly coming up mid-year this year, there'll need to be some action. And so, I mean, we're really hopeful the language will look, the coverage will look like what we want to look like. But we don't take anything for granted. We don't assume it will. This has been, like I said, a very educational, process for us educating, CMS. But I will say though, they have been very open to our information. I've been very impressed with our interactions with CMS, and we've been interacting with them. We met with them last summer again, because we've always asked, can you just cover this on your own? And they've said, unfortunately, we can't. So our interactions with members of Congress and CMS have always been very positive. Again, this was more of a slip through the crack type of situation. We've actually never heard anyone oppose, anyone say, no, patients don't need compression. It was just how can we, under the rules of how the government functions and things, how can we get this, coverage implemented?
Well, congratulations, first of all, on making this happen. This has been such a long journey. Like I said, I heard about it for the first time in 2018, but I knew that it had been going on for a while before then.
Yes.
And I know we're not done. I know there's still work to do, but I really want to commend you and just all the work that you and your colleagues and your teams have been doing, because this is so exciting, and it's a step in the right direction that we've been hoping for so long. And I just really appreciate all the work that you and everyone else have been doing for this. So thank you, Sarah.
No, and we couldn't do it without, we're leading things, but there have been so many times, and we know therapists are so busy in their daily schedules, not even to mention their personal schedules, just their daily schedules. But anytime we've needed something, the groups have been supportive. Anytime, there's been times we've been maybe trying to get a meeting with a specific member of Congress, we'll go to the LANA, directory and see who's in that area. And sometimes we found a therapist who will jump on a call with us and be helpful. So, it's kind of interesting. Sometimes it feels frustrating that the patients or the patients' families have to, advocate for this, but we know we've had, I joke, I have more time than anything else because I'm on disability. And so that's why, we've took it on.